Hi, I'm Laura. I'm a student nurse.
Hi, I'm Brianna.
Can I have S-bar on our patient, please?
Sure. So the patient's name is Ronald Jarvis in room 622. He's 67-year-old, admitted yesterday. The patient's code status is full code, no known allergies, and Dr. Phillips is his doctor. The patient came in with a non-healing wound on the right heel and high blood glucose readings. The blood glucose readings have been high for 5 days with results consistently in the 300s. The wound on the right heel he noticed approximately 3 weeks ago. The patient is a type 1 diabetic for approximately 20 years. Until 3 weeks ago, the patient was running consistent blood glucose levels in the 120 range with his last A1C check 3 months ago with a result of 5.2. So a little bit of background, the patient reports that he follows an 1,800 calorie diet with a decreased adherence over the past 9 months, and he'd like some education on the diabetic diet. He denies tobacco use and admits to drinking 1 beer every Friday while bowling. He has no formal exercise besides the bowling on Fridays. The meds that he's taking right now is lisinopril, hydrochlorothiazide, insulin glargine, regular insulin, simvastatin, morphine sulfate for pain, and gabapentin. So upon my assessment, my vital signs were blood pressure is 128/70, the respiratory rate is 16, pulse 76, and O2 sat was 96%. The patient is alert and oriented ×4. All assessments were unremarkable with the exception of an IV in the right forearm for morphine sulfate injections for pain. The lesion on the right heel that Mr. Jarvis says is increasingly painful. He tried soaking it at home in salt water with no relief. The wound is 3 centimeters deep, extending into the dermis, no tunneling or undermining. The ulcer has partial thickness loss, presenting as a shallow open ulcer. The neuropathy presents bilaterally in lower extremities, and he notes that it has actually worsened over the last 3 months. Some recommendations for the patient. He's being treated for glucose control, pain management, and wound care. His current blood glucose is 242, so we're going to administer insulin glargine 18 units sub-Q, and that's given daily at the same time. We're also going to administer regular insulin 16 units and giving that 30 to 60 minutes before he eats 4 times a day. That's based on a sliding scale. So I recommend we make sure that the patient is turning every 2 hours to prevent the development of other ulcers. Also monitor the patient for signs of hypoglycemia after we give both insulins. Also recommend changing the dressing 2 times a day until we consult with the wound care team. And lastly, recommend educating the patient on the diabetic diet and giving him information on his medications.
That sounds great. I have a couple questions for you in regards to the medications before we go administer them.
Okay.
Why specifically is the client receiving this medication?
Well, the patient is a type 1 diabetic and he's insulin dependent, so he needs to get the insulin injections.
What action does the medication have on the body?
The insulin increases the glucose uptake in cells and inhibits the glucose production in the liver.
When should you question administering this medication?
You should question it if the blood sugar is less than 70 or greater than 300. If it's less than 70, we can cause hypoglycemia. And if it's greater than 300, we want to call the PCP. Also, if the patient refuses to eat.
Does the medication have a therapeutic serum level?
Not necessarily, but we want to try to monitor, make sure the blood glucose stays between 60 and 100.
Which vital signs must be monitored?
All vital signs are important, but we want to monitor heart rate and blood pressure and look for signs of hypoglycemia.
Which physiological parameters should be monitored when the medication is being administered?
So when the medication is being administered, we want to look for any signs of allergic reaction at the injection site, like swelling and also anaphylactic reaction. Also look for signs of hypoglycemia, like diaphoresis, cold and clammy skin, and changes in neurological status.
What interventions must be taught to the client to ensure the medication is administered safely both in the hospital as well as at home?
Well, they're both going to kind of be the same, but in the hospital it's more controlled. We want to make sure that the patient checks the expiration date on the bottle, make sure they're rotating their injection sites to prevent lipodystrophy, make sure they're checking at the bottle that the medication is clear and not cloudy. Also check their blood sugar before they administer the medication and call their primary care provider with any new medications.
What are the side effects and potential adverse reactions?
The potential side effects and adverse reactions include anaphylactic reaction, like I said before, also hypoglycemia, diaphoresis, cold and clammy skin, changes in neurological status.
How will you know the medication is effective?
We'll know the medication is effective if the blood glucose goes down.
That's great. Those are all my questions for now.
Okay.
Let's go administer the insulin.
Okay, let's go. Knock, knock, knock.
Come on in.
Hello, how are you today?
I'm okay. How are you?
Good. Well, I'm Brianna. I'll be your nurse today. And this is Laura. She's a student nurse.
Hi.
Guys.
All right, so we're going to be giving you your insulin today. We checked your blood sugar. It was 242, so we're going to give you your regular insulin and the Glargine, okay?
Okay.
All right, can you state your name and date of birth for me?
I'm Ronald Jarvis and I'm 67.
Awesome. And any allergies?
Nope.
All right. So expiration date on both bottles is good. Okay, just gonna scan your armband real quick.
Absolutely, sure. Treatment of a patient with Glargine, he's 67 years old, in room 620, Phillips, Mary's Head. He has no allergies, he's a full code.
All right, so we're gonna check the medication against the MAR. Right patient, we checked right time, 2200. Right route is sub-Q, 18 units, and we checked the medication, which is Glargine.
I forgot that we're just going to get through that.
I can't, but you said
All right, and we're gonna also check the other medication against the MAR. And I'm gonna try it again. And the other insulin. All right, so we have regular insulin, 16 units, sub-Q, 2100, and the right patient. Can you state your name and date of birth for me again?
Ronald Jarvis, still 67.
All right.
I don't know, man.
And any allergies?
Nope.
So before we draw it up, we'll check it one more time. So Glargine, 18 units, sub-Q, 2200, right patient.
No allergies, full
All
code.
right.
He has a 1800 calorie diabetic diet.
And we're gonna check the regular insulin again, 18 units, sub-Q, 2100. All right, you wanna make sure you check your 5 rights every time you have your medication.
Sounds good.
So we're gonna draw up both insulins now.
Can you draw them up in the same syringe?
No, you'll have to draw them up into different syringes, because you don't mix these. Okay, so with the regular insulin, we're gonna drop 16 units, so we're gonna drop 16 units of air first.
Current A1C is 6.5, last A1C was 5.2, and up until about 3 weeks ago, his blood
Okay,
sugar was
then we're gonna put 16 units of insulin, of air in,
fasting blood glucose was 310, calcium was 7.4, and potassium
and
was
draw up
3.4.
16 units.
Acceptable assessment was unremarkable, except for the notation of diabetic ulcer in the right field. Neurological exam was unremarkable.
So this one is
Glucose was
good.
at 200.
Now we're gonna draw up 18 units of Glargine, and we're gonna draw up 18 units of air first,
Monitor blood glucose, keep on a diabetic diet,
and put in those 18 units of air,
and teach proper foot and wound care too as well.
and draw up
Okay,
18
why
units.
specifically is this client receiving the insulin we're about to give?
He's receiving this because he's type 1 diabetic and he's currently a hyperglycemic, 290.
All right, so we have both our insulins drawn up, and now we're gonna do our last check of all the medications.
That's going to increase the glucose.
All right, so we have our regular insulin, 16 units, sub-Q, 2100. State your name and date of birth for me one more time.
Ronald Jarvis, 67.
And any allergies? Okay. And checking the Glargine one more time, sub-Q, 18 units, 2200, right patient, and right medication.
Check, baby, check, baby.
All right, so I noticed in the MAR that last time you had them in the left lower quadrant, so this time I'm going to do the right lower. Is that okay with you?
Yep, sounds
Okay.
good.
And any pain or anything right now?
Oh, my foot is like a 1, but nothing bad. The aspirin's doing pretty well.
All right. So we're going to clean the injections in here. Going to clean the whole quadrant. Okay, so we're going to administer the Glargine first.
Okay, so what interventions do you have to teach the client?
And your regular insulin.
Administered safely in the hospital setting and at home?
We're at the hospital, we're going to tell them to...
All right, doing okay?
Yeah, thanks, Bree. That was quick and easy.
You're welcome. All right, so I saw that you requested some education on your diabetic diet, correct?
Yeah.
Okay. Well, I do have a pamphlet for you. So the main things you want to control is your intake of alcohol. Try to limit it to 1 drink a day or less if you can. Limit your carbs to 60 grams a meal. Also try to stay away from any sugars. Try to increase your intake of lean meats, fruits and vegetables, simple carbs. So there's a pamphlet for you.
Oh, okay.
Okay. Do you have any questions at all?
Nope, I'm good to go.
Okay. And I'm going to be back in to check on you. Your meal should be here in about 30 minutes. Okay?
Sounds good. I'm hungry.
All right. All right. Well, you have a good day. We'll be back in soon, okay?
Thank you.
You're welcome.
Thanks for letting me watch.
No problem, student.
How are you? Very well. My name is Jeremy.
All right, do you have any questions for me?
Of course.
Okay.
Were there any pertinent pieces of information you reviewed before administering the client's medication?
Yes, we checked the blood glucose. That was 242, so that was within the parameters for administration. Also, I checked the potassium level, which was normal. We want to make sure that it's not low, so we don't we prevent hypokalemia.
Did this information affect your decision to administer the medication?
Yes, the blood glucose had to be within parameters for administration. If it was too low, less than 70, or too high, greater than 300, we wouldn't administer it.
Check your medication tomorrow.
And did this information affect how you administered the medication?
No, they were ordered sub-Q. Regular insulin can be given IV, but that wasn't the way it was ordered. So we gave both insulin sub-Q.
Excellent. Those are all my questions.
Okay.
Thank you so much for letting me follow you.
You're welcome.